Colleagues, in partnership with Nephrology, Dialysis, Transplantation, NDT, the official journal of the European Renal Association, MARKUS HOMe welcomes Professor Marc Vervloet in Nijmegen and Professor Pieter Evenepoel in Leuven to discuss part 2 of the recommendation on calcium intake in CKD patients, this time focusing upon adult patients, and also to have an outlook on recommendations on vitamin D intake. Dear Peter, dear Marc, it's a pleasure to host you tonight.
Pieter Evenepoel is Associate Professor at the Faculty of Medicine and Adjunct Head of Nephrology at the University Hospital of the Catholic University of Leuven in Belgium. Marc Vervloet is the Professor of Nephrology at Radboud University Medical Center at Radboud University, Head of the Department of Nephrology at Radboud UMC in Nijmegen. And together with Gunnar and myself, it's a great pleasure to welcome for the first time my colleague in Austria, Professor Daniel Ceca, who is Head of Department of the Third Internal Medicine at the Ordensklinikum in Linz and is an designated expert in CKD MBD and the co-chair of the ERA working group. So welcome, everyone.
Thank you. It's a pleasure to be here.
So thank you for the kind invitation. It's really like an honor to be able to present this publication, which has been published very recently, dealing with the calcium intake in CKD patients. So you had the first part some days ago with Ruxana Sharov, who was discussing calcium intake in kids and young people. And this time we will focus on the calcium intake in adult patients with CKD. So these are my disclosures, and just to start with a short introduction. So it will not be able to discuss the whole paper, which is more than 12 pages during this 5 or 10 minutes talk. So I will have to focus on some details. And I would like to start with this very short background, because I started as a nephrologist something like 20 years ago. And in that time, the focus was on controlling hyperparathyroidism. At that time, we prescribed almost tons of calcium to our patients to keep the PTH in a well, let's say, controlled range. And also we used active vitamin D to achieve this goal. Around the millennium turn, we became aware of the, let's say, important burden of vascular calcification in our patients. And one of the culprits was potentially calcium and the high calcium intake that we gave our patients. At that time, we shifted from calcium-containing phosphate binders to using calcium-free phosphate binders. And also with the emergence of the calciumimetics, we shifted from active vitamin D to calciumimetics for the control of PTH. So there was, in a way, a shift from high calcium intake to low calcium intake. And as calcium is important also for the bone as one of the bricks to build bone, potentially this could result in too little calcium that we're giving our patients at this time. So there is a knowledge gap in a way that we don't know at this moment what is in fact the optimal calcium intake in adults and children with CKD. And to fill this gap, we convened, and I mean the EUROT group in collaboration with other ERA working groups and also with ERCnet, convened a group of experts in the field of CKD and MBD to address this issue. And we formulated several questions, and this at the end result is in this publication that's now published in NDT. We formulated some questions, and these questions are: what is the recommended intake of calcium in healthy individuals of different ages? Question 2 is: what are the determinants of calcium balance in CKD? Question 3 is: what is the recommended daily intake of calcium in patients with CKD? And finally, what should be the approach to hypo and hypercalcemia? And we produce some key evidence points, which in fact are a bit the summary of the available evidence, and also some clinical practice points, so clinical practice recommendations. Important, this was not a formal guideline, so this should be considered as guidance paper, not a formal guideline paper. In a way, I would just try to discuss one of the questions or two questions. And the first question is: what's the recommended daily intake of calcium in patients with CKD? And as said yesterday, in children, it should be the age-appropriate normal range. While in adults, we concluded that we suggest a minimum calcium intake of 800 to 1000 milligrams per day to maintain a neutral calcium balance. And we should suggest not to exceed a total calcium intake of 1500 milligrams to avoid hypercalcemia and the risk of vascular calcification. So the kids have been discussed yesterday. What about the adults? As said again, too little would mean below 800 milligrams per day, and too much would mean above 1,500 milligrams. How did we arrive at these levels? So first, with regard to the minimum, which we set to be around 800 to 1,000 milligrams, this is mainly based on two formal calcium balance studies that has been published a while ago. And you can see in these graphs that patients on an intake of around 800 milligrams per day, that their calcium balance is neutral to even slightly negative. And this was the case in these two studies. Also, we know from recent randomized controlled trials that there is no excess mortality with calcium-containing phosphate binders. This is most of all important, the famous landmark trial, which was in Japan, and they compared lanthanum carbonate to calcium carbonate, and in a way, although these patients were given completely different calcium content, at the end, there was no difference in the heart outcomes being a composite of cardiovascular events. So this was reassuring data, as you also can see on this graph. So not at all any difference between the two arms, lanthanum carbonate and calcium carbonate, in the primary and also in the secondary endpoints. And not unexpected, of course, when you use calcium carbonate, you will be able to control PTH to better extent than when you use lanthanum carbonate. So that could be even an advantage. So knowing this 800 to 1,000 milligrams as being the ideal target level, in a way, this is completely consistent with the guideline that has been published by by the Kadoki group, recently. So it's also the same range. This is how do the habitual intake of our patients do relate to this target. And just to show this graph, it's for me very important to emphasize that the evidence is very little. So if you look at all these studies that we compiled, it's low numbers. But if you then try to summarize it, you can see that the majority of patients with CKD stage grade 2 to grade 5, and also the patients on dialysis, the majority of the patients do have a calcium intake which is below the target that we have set. So that certainly should be an eye-opener. At least patients not giving any calcium supplements just because of dietary restrictions. And you know, calcium intake is in parallel to phosphate intake, and we advocate our patients to restrict phosphate intake. So this goes along with a low calcium intake, which is below the target range that we have set forward. The other, what's too much then? And too much is 1,500 milligrams. This is based on the fact, again, coming evidence from the calcium balance studies, where we have shown, or these authors have shown, that when you add calcium to the diet by calcium supplements, and in the one study it was 2,000 milligrams, in the other study it was 2,500 milligrams, you can see that these patients end up with a positive calcium balance. And also in other studies, this calcium, high calcium intake goes along with demonstration of progression of vascular calcification. So we consider a calcium intake of 1,500 milligrams as being the upper limit of safe intake. Second question is how we can assess the calcium requirements in clinical practice. In a way, this should be a combination of surveys, dietary surveys. Also consider the calcium transfers during dialysis. I will not discuss in detail, but also dialysate could be a source of calcium, of exogenous calcium loading. We can have a look at the biomarkers, because a high bone turnover is indicative of a too low calcium, that calcium needs to be released from the skeleton. And finally, also a DEXA scan gives you a long-term insight in what's the calcium balance of your patient. So a low DEXA scan means that patient has been deprived of calcium for a long time. And that then we should result in interventions where we could use diet, calcium-containing phosphate binders or supplements, or also calcium in the dialysis fluid to replenish the calcium intake. And we advocate, and that's something which is certainly will be new, and many centers don't do it, but at least our patients in the bone clinic do it on a regular basis, is to evaluate, to assess the calcium intake by using this kind of surveys. And we should advocate to do it on a regular basis at first presentation, then every 12 months, and also in patients who are presenting with hypo or hypercalcemia, and also before or after adjusting therapy for secondary hyperparathyroidism or osteoporosis. So I think this is very ambitious, but I think if we could start already with measuring and analyzing calcium intake in our patients, that will open the eyes, because we will see in many of our patients a calcium intake which is really low. Short words on hypo and hypercalcemia. So I think that we produce this clinical practice point that acute iatrogenic hypocalcemia should be corrected with calcium supplementation, active vitamin D, and or a temporary increase in diazide calcium. And we also suggest, and that's something which is very actual, there was a recent paper in JAMA concerning the risk of hypocalcemia following denosumab. That's an avoidable complication. So if we know about it, we should pre-treat our patients eventually with active vitamin D or calcium supplements if we predict there will be a post-treatment hypocalcemic event. And also we should, and that's something we should do on a more regular basis, if we face a patient with chronic hypocalcemia, the first thing to do is to assess the calcium status by looking at, for example, the survey, dietary survey, looking at the biomarkers of bone turnover, and eventually also a DEXA scan. So that was, in fact, in a nutshell, what we discussed, and I would recommend to go through this paper. It's written also in bullet points, so if you don't have much time, you can just have a look at the bullet points, and you will learn a lot on how to deal with your patients with regard to the calcium intake. Thank you.
So another part that the EUROD, which is a body of the CKD MBD working group of ERA, is now working on is the controversial issue if we should supplement vitamin D in people with CKD. And we restrict the discussion, and I will restrict the restricted discussion this evening only to what we term nutritional or supplemental vitamin D. And I'm happy to also discuss about active vitamin D, but this will be the focus for now. These are my disclosures. And first of all, it's important to state that defining vitamin D insufficiency or deficiency is not straightforward at all. And actually, this also applies to the general population. And in general, vitamin D sufficiency is defined as a level of vitamin D above which there is no additional decline of PTH. So as you know, vitamin D system and PTA hormone are in close relation. Vitamin D is suppressing PTH. And if, as I just said, if there is no additional suppression of PTH, then you have a level of vitamin D which is assumed to be sufficient. And in the general population, this is around 50 millimolars per liter, which is 20 milligrams per deciliter, as indicated on the figure on the left-hand side. It is important to note that there is a difference in vitamin D metabolism and possibly also in vitamin D's sensitivity in people with CKD, which you can see on the right-hand side. And if you would have the same definition for vitamin D sufficiency, then the levels might be much higher, what you should aim for, because there is a linear relationship between PTH, or an inverse linear relationship between PTH and 25D levels in people with CKD, which suggests that the higher the 25D level is, the lower you are able to suppress PTH. And in this figure, there appears to be no upper limit at all. I'm not advocating that we should aim for skyrocketing 25D levels, but it does indicate that the metabolism of vitamin D is different for people with chronic kidney disease. And this exemplifies this. And this is a slide I borrowed from Pieter and Hanne Jurgensen, which summarizes what might be going on. And as you all know, Supplemental vitamin D is not the active compound or hardly has any effect on the vitamin D receptor, but active vitamin D is. And nutritional vitamin D is the substrate for the conversion to active vitamin D. And this is the conceptual idea what is going on in CKD. And what you can see in the green line, that even if you have quite low levels of 25D, your system is capable to converting that to active vitamin D at quite low levels already. But this appears to be hampered for people with CKD. So active vitamin D levels, so 125 dihydroxycholecalciferol, seems to be much more substrate dependent, which could explain the figure I showed you in the previous slide, that higher levels of 25D still provide additional suppression of PTH. One of the key issues we have to deal with is the huge discordant finding we have with observational data for 25D levels and mortality, which I show you on this graph, and clinical trials I will show you in the next one. So what you see here is that observational studies, and this is just one from the NHANE study, show that for any subgroup, mortality risk is lower for people who have 25D levels above 75 nanomole per liter compared to people with 25D levels below 37.5. And you can see this is exceedingly consistent. So many observational data like this suggest that we should supplement vitamin D if it's deficient to improve mortality. I will come back to the mortality issue as well, because these data I just talked about are mainly looking at the association of 25D levels and mortality. And I will talk a bit on the effects of vitamin D levels and bone and calcium balance. So these are observational data, but you are probably aware of the very disappointing results of trial data. And this is just one example, and there are a few more. And this is from the VITAL study, in which patients were randomized to receive placebo or vitamin D. And the primary endpoints of this study was mortality and incidence of cancer. And both were, well, it cannot be hardly any more nil than it is. So there's no effect at all in this study. And you might be aware that also looking at patients with some decline in kidney function, because these were not patients with kidney disease, there was no effect modification of having lower eGFRs in this general population study. It is important to realize that one of the exclusion criteria in VITAL was the having overt cardiovascular disease. But nevertheless, having these limitations in mind, there is no effect at all on mortality in the trial. So what would be the way forward? How can we explain this discrepancy? Well, one of the main things to consider is what I just mentioned, that it is possible that in people with CKD things are different. And another explanation I will show you in the next few slides. So this is a study from 2022, which did a Mendelian randomization study in which the predicted effect of the predicted level of 25D was associated to mortality, and this was done in a huge biobank, which is the UK biobank participants. And the nice part of doing Mendelian randomization is that you can exclude confounders. And what did they find? In this study, it was shown that for all-cause mortality, cancer mortality on the top right-hand side, cardiovascular mortality, and respiratory mortality, the lower the 25D levels are, the higher the risk. But I would like to draw your attention to the fact that these upslope of mortality risk starts off for all these endpoints somewhere in the range of 25 nanomoles per liter, as you can see. So if you want to design a trial to look at the effects on one of these four endpoints, you should recruit patients at risk. which is indicated here in the pink. So it's not at forehand very likely that if you recruit patients with an 25D levels of 50 nanomoles per liter, you will find much of a difference. And if you now look at the vitamin D levels of people who were recruited in VITAL, you can see that in the panels on top on the left-hand side as an example. So the average 25D levels in VITAL in the people in whom it was measured, because that was not done in all, was over 75, and the horizontal arrows indicate the standard deviation. So actually, if you see this, one should not be very surprised that the trial was negative. And remember that in people with chronic kidney disease, things might even be more important, because they might have vitamin D or active vitamin D levels which are lower already at higher levels of 25D. So despite the fact that the VITAL trial was completely negative on any endpoint, the point I want to make is that we cannot exclude the possibility that for people who are more vitamin D deficient, and especially in people with CKD, they still might benefit. We don't know this. As I mentioned, the VITAL study was in the general population. And I also mentioned that this was looking at mortality, but what about vitamin D and fracture risk in the general population? And not all studies found an effect, but one of the first studies is on top of this list, which is Chapuy. Maybe I don't pronounce it rightly, but he or she studied the effect of vitamin D supplements combined with calcium, and there was a tremendous effect on reducing the hip fracture risk and non-hip fracture risk. It is important to realize that this was a really frail population. I think, if I remember well, their age was in the range of 80 years old, and these were institutionalized women. So this is a very high risk population with a high likelihood of being vitamin D deficient. Not all studies were negative, but the trend in general was favoring the use of 25D supplements, but one study was positive as well, which is the latter one. So there is a hint that if you give 25D combined with calcium, you might actually reduce fracture risk in the general population. Surprisingly, this was not extensively studied in people with CKD, and the few studies that did look at this are reflected here. There is no statistically significant effect, but look at the numbers. So this was really low numbers in these studies, and actually the conclusion should be that this has never been studied adequately. It is important to know that if you give vitamin D or active vitamin D in a setting of low calcium, as Pieter just mentioned, this actually might deprive bone calcium, because vitamin D is a calciotropic hormone. And if there is not sufficient amount of calcium in the circulation or any other stores, it can actually lead to deprivation of calcium from bone. So the conclusions are that vitamin D metabolism is disturbed in CKD. Nothing new here, but important to realize. There is no proof of benefit of vitamin D on mortality, nor any non-bone outcome. So this is about the assumed pleiotropic effects of vitamin D. However, most studies, which also applies to the VITAL, was performed in people without overt vitamin D deficiency, as I showed you. And there are data that suggest a benefit of 25D supplementation on bone, especially when combined with adequate calcium intake from diet or by supplements. So that's it. And as I already mentioned in the beginning, the EURAT group is working on a consensus statement on this. I hope we will finish this in a few months. And in the meanwhile, spring is coming and sun is coming, and that's also a nice way to supplement your own 25D levels. So that's it. And I give the floor back to the chair.
Well, thank you, Marc and Pieter, for this excellent overview. And we are definitely curious to see the vitamin D part getting published soon. I will hand over to Daniel now to, his first questions.
Yeah, thank you very much, Peter and Mark. Excellent presentations, as always. Now, you left us with a little bit of a cliffhanger, Mark, teasing us with an upcoming publication, but maybe you want to provide us with a little bit of a spoiler, and this is actually a question to both of you. What do you think the minimum acceptable 25 vitamin D level is in dialysis patients? Because the current KDIGO recommendations suggest that 25D may be measured without giving any guidance what the consequence then should be. And there's a lot of controversy in it, as you know, to give active vitamin D instead of nutritional vitamin D, for instance. So I would really love to hear both of your thoughts, please.
Shall I kick off, Peter? Well, I can, of course, answer that, but I'm a bit reluctant to do so because I don't want to put any authority to my answer. So that's the disclaimer. In general, I would prefer to start with supplemental vitamin D instead of active vitamin D. One of the reasons is that the kinetics of active vitamin D is very short. So you supplement for a short period of time, and active vitamin D actually can deplete 25D levels by activating its catabolism. So the first thing I would do is first make sure that the amount of 25D is sufficient. It's very thin ice to give a number to what the minimum level should be. In turn, we could consider if there is an upper limit of safety below which you should stay. And I would say, well, I personally would not have it going above 100 to 120 nanomoles per liter. And I would act, if I would have measured it, if it was below 50. So, but this is opinion. And this is what I do. So I supplement it usually, and only if I have additional indication that there is more need for 125D, then I consider 125D on top of that. That's what I do. Peter.
So I do agree, Mark, but this is a topic of discussion going on now in the Europe group on which indeed the level that we should recommend. And I mean, it's a little bit difficult to now disclaim or to report what we both believe. But I mean, it just is our belief, but it still needs to go through the whole process of, let's say, discussion in the whole group. I would favor a little bit higher than Mark is suggesting. So I would go more like above 75, meaning 30 nanograms per ml. In a way that certainly vitamin, it's just based on this kind of concept of that in patients with CKD, it's really like a substrate-driven activity. So it's not all regulated anymore by PTH and FGF23. It's more like a substrate-driven issue. And I do believe that certainly before you start with active vitamin D supplementation, you first need to deplete 25D above 30 nanograms per ml. And I would personally, but again, this is personal opinion, nothing more than personal opinion. I would even go through 50 nanograms per ml as being some kind of a higher target than which is now being proposed by in general population, because I do believe that this important substrate-driven factor. We will publish in very soon a paper where we investigated vitamin D metabolism in anephric patients, and it's really confirming completely that there is possibility to produce 125 if you supplement sufficient 25. And if we do believe that 125 is important as being, let's say, the active vitamin D and having the effects that we believe are good effects, then we need to supplement 25. I want to go back to your data on this annals of internal medicine, where you see that the increase in mortality starts when the 25 levels are below the 25 nanomoles per liter, meaning like 10 nanograms per ml. So that's really at the moment when this kind of homeostatic hormonal pathways become completely inefficient or completely they will start to fail. Once above 10 nanograms per ml, you will be able to maintain 125 in the normal range. But when you drop your 25 below this level, then you will have 125 in the insufficient range. But in CKD, it's different. There you need to target higher levels to get 125 in the normal level. This is just hypothetical. This is just like a hypothesis, but I think this is supporting me in my idea that we need to go to higher levels of 25 in patients with CKD.
Yeah, and I completely can echo that the lower level for people with CKD is likely quite higher than the lower level in the general population. Yeah. And I would like also to bring back to your memory what I showed from this Mendelian randomization study, that in people who have low level, they likely are still capable to produce sufficient amount of 125D. And this should be prioritized to supplement that before you go to active vitamin D. There might also be actually drawbacks of giving 125D more early. As I mentioned, it can deprive calcium from bone, it can increase FGF23, it can lead to bouts of uptake of phosphate, for instance. And this is the reason why, in general, I think we agree that we should be more reluctant to give 125D if there is not sufficient amount of 25D.
Thank you very much for both of your answers. Because the reason I asked was personal observation, because until recently we did not measure 25D at our unit, at our dialysis unit, because of lack of recommendation, so to say, and also because of cost. Now costs have come down substantially, so we just introduced it this year. That every patient gets a 25D level once yearly, at least. And there I made a very interesting observation that we have not too few patients who have 25D levels of 9, 11. This is picograms. Picograms. At the same time, they have a PTH level of 200 to 300, again picograms, and alkaline phosphatase levels very low, 50, 60, 70. This is total alkaline phosphatase units. And this is very interesting because one would expect osteomalacia in those patients, but we don't have any evidence for that. We don't have bone biopsies, of course, but we don't have any bone pain in those patients. They have low alkaline phosphatase, and many of them are on calcitriol supplementation. So this really made me wonder how important this vitamin 25, vitamin D, really is, also from the bone perspective, or whether it's not only a marker of frailty.
Yeah, I would say to some extent these patients likely would have sufficient amount of calcium, which
they're normocalcemic. That's true. Yeah. I mean, I don't know about uptake, of course, but at least serum calcium, which is a poor marker of balance, of course, is normal at least. That's true.
So the osteomalacia you don't see might be the consequence of, for one way or the other, still being calcium replete.
Yeah. Mm-hmm. I'm a bit reluctant for using active vitamin D, Daniel, because I think there you have more risk of hypercalcemia in your patients. And I do really believe that not the calcium balance is that important, but it's the hypercalcemia which is driving the association with poor outcomes. And again, with active vitamin D, it's an hormone. It's acting. It can act on the bone directly, like Marc told you, and could cause hypercalcemia, which is detrimental. While this is not occurring, at least not when you avoid the excessively high levels of 25D with vitamin D, with nutritional vitamin D supplementation. So that's the reason why, at least in our unit, there is almost no active vitamin D anymore.
Also not in dialysis patients. So not only in non-dialysis CKD, but also in dialysis patients, you hardly give any active vitamin D?
at least less, and certainly not the high doses that sometimes in the past were given IV of 2 micrograms every dialysis, for example. No, we don't do it because we fear the hypercalcemia, and nowadays we have other potent drugs to suppress PTH. So we more, let's say, invest in optimizing nutritional vitamin D stores and try to avoid active vitamin D. But
Yeah.
it's again in the guidelines. The KDIGO doesn't make any distinction between active vitamin D versus Cinacalcet, so there is no proof of the one is better than the other. So it's still it's eminence based in a way, but not evidence based.
Yeah, but there is a logical choice would be to use active vitamin D in a setting of high PTH and quite low calcium levels. Then it doesn't make sense to start with Cinacalcet. That's how we use it.
Yeah.
Again, I would like to stress that this is based on clinical reasoning and not on trial data. We have reasons to assume that if you induce hypocalcemia by calcimimetics, it might be detrimental. So I think we should be careful on that. And frequently, if you need to suppress PTH, leaving the discussion when you should do so apart, a combination of calcimimetic with a low dose of active vitamin D might be helpful.
Yeah. I mean, we have these drugs available, so we need to look for the best combination at the end. Yeah.
Maybe if I may add, also from my point of view, a very strong pro for nutritional vitamin D is a very favorable safety profile.
Yeah.
Yeah, but I think I would like to stress, as I try to demonstrate in the slides, that the evidence base to do so is very weak. So this is common practice. It's completely logical. It seems to be safe. But in terms of compliance of patients, it's important to keep in mind that patients might choose to just take a few pills less. And if they continue using nutritional vitamin D and stop taking statins or blood pressure medication, then we're in the wrong path.
Why do you think that it's so difficult to create evidence? Because we all have a lot of CKD patients and we also have a lot of dialysis patients.
That's the $1 million question. Why are we as nephrologists not able to provide the evidence? We all need to advance the therapy. That's right, Andreas. I don't know why.
Yeah.
I'm a strong believer. Certainly, there will be no financial support from the companies because it's such a, cheap drug, and so it should come from investigator-driven studies using the new strategies, not randomized controlled trial, but pragmatic trials is something that certainly is the case. And as you know, there is a big trial running in the UK with vitamin D, which I hope the results will be available at the end of 2025. So there will come some answers from these pragmatic trials. So for sure, but for the moment, we don't have the evidence we need.
Yeah, but the question that pops up as well is, if you would do such a trial, what would be the endpoint? So what are we interested in? So if we are looking for vitamin D and cardiovascular or mortality outcomes, this will probably need to be a very huge study in people with high baseline risk. And these patients have a short lifespan. But this is going to be difficult, and the mortality risk is always multifactorial. So if we do one single intervention in a high-risk population, it's most likely that the study will be negative unless we recruit 20,000.
Mm-hmm. But then the pragmatic trial design is coming as a solution in a way. So I do believe that this UK trial is looking at hard endpoints. So I don't know whether they will be successful because of pragmatic trials do have some kinds of limitations. But at the end, this is the best which is achievable and what we should wait for.
Yeah.
But do you think that, for instance, looking at fractures would be more appropriate?
But we all believe, at least I do believe, that PTH is a major driver of bone fragility in our patients, and that of course fractures as an outcome would be very important, and certainly it's reasonable when you investigate vitamin D. So it should be included. Yes, for sure. Yes.
I completely agree with that. So the most logical endpoint would be a bone-related endpoint.
Yeah. There we have the most evidence with vitamin D. So we have lots of the same, I mean, calcium also. I mean, it's suppressing PTH. We have this massive, this high PTH in Europe, United States. We don't have them in Japan for different reasons, which are not always that clear. But PTH certainly is too high, and you know, we are now working on a KDIGO update, and we had the Controversies conference in Madrid in September, and one of the, I think, these important changes that will come out of this Controversies and this KDIGO update is that there will be put more emphasis on bone turnover as a readout of the bone phenotype and moving away from PTH.
Mm-hmm.
So we will have potentially bone turnover as being an outcome measure, but of course the hardest outcome is fracture at the end, but not PTH. No.
And how do you measure bone turnover? Is it like ELK FOS in general? Or?
Yeah, that's a very good question, Andreas, and it's certainly also a moving field. We have been using bone turnover markers, not routine practice in most centers, even not in my center, although we have a very bone-specific interest. We were, I would say, tomorrow we will implement in the daily routine the measurement of novel bone turnover markers. So in daily routine, meaning that we will use the bone-specific alkaline phosphatase and the TRAP5B, which is a bone resorption marker, both bone biomarkers which are not affected by kidney function, which is in the setting of dialysis not that important, but certainly it's important in the setting of patients with a variable kidney function. But we will implement, and I think this is really like a big changer, that this will become, I hope, and I do believe it's an important additional biomarker that we will measure in the routine practice. And awaiting the implementation of these novel biomarkers in your unit, you certainly could have a look at alkaline phosphatase. That's what I'm teaching to my fellows is look at we have been learned by CKD, MBD guidelines to look at calcium phosphate PTH in aggregate, but we also should include alkaline phosphatase and a trend in alkaline phosphatase. When you see an increasing trend of alkaline phosphatase in the absence of liver dysfunction, that's for sure a bad sign. I mean, this is pointing to high bone turnover, and you need then to act on the PTH, which could be 2 times the upper limit or 9 times the upper limit. But the alkaline phosphatase is a more robust biomarker than PTH as bone outcomes are concerned.
This is an additional issue of controversy, which has also been discussed at this KDIGO Controversies conference. What we should do with PTH, because this 2 to 9 times upper limit of normal issue is a wide range, and it's important to realize that this is based on mortality outcome and not on bone outcome. And for bone outcome, you can deal with the issue of PTH resistance. If you look at bone turnover markers, then you overcome this issue.
Yeah.
And actually, PTH resistance might in turn somehow be reflecting mortality risk, and then PTH is high, but reflecting PTH resistance.
I would like to briefly come back to the idea of this poor evidence in this field. So might it be that it's still too easy for companies to bring new medication on the market in the field of CKD, MBD in comparison to, for example, anti-diabetic drugs, where you have to prove safety in very large trials, whereas we can still, to my best understanding, still bring new medication, new phosphorus binders on the market based only on surrogate markers?
Yeah, I think that is an issue. But if you would require hard clinical endpoints data for novel phosphate binders, for instance, to come to the market, then there won't be any novel phosphate binders. So an issue with phosphate binders, well, I would advocate that an endpoint could also be phosphate control in parallel with adherence to treatment or quality of life issues. And we have some recent phosphate binders that reduce the pill burden. I think that's a benefit for the patients. So if you can lower pill burden and have phosphate control compared to all the binders which either provide too high calcium intake or up to 12 phosphate binders per day, then I would be happy if FDA and EMA would accept such a compound.
Did you increase the use of calcium-based phosphate binders in recent years? Because my idea is that 20 years ago, 15 years ago, we were told so often that calcium-based phosphate binders are so dangerous based upon calcifications. Now we have the studies that you showed us, and we do not have this large input from industry anymore. And my personal view is that we go back to use calcium binders more often, also in line with the idea of your recommendations that we should not restrict calcium uptake to a too low limit.
Yeah, I completely agree, Gunnar. That's certainly that's the aim of this recommendation. So some centers are have banned completely calcium-containing phosphate binders and using only the calcium-free phosphate binders, and this exposes their patients at a certain risk. And so yes, we always had in our center we kept on using calcium phosphate binders as a first drug, but as I remember as a fellow 20 years ago, we were prescribing 8-9 grams of calcium carbonate to our patients. Of course, that we never will do again, but 1 gram, 2 grams, okay, and then we move to a calcium free. So we use combinations, but we start with a calcium containing phosphate binders. And as said, we will implement this calcium survey, looking at the calcium intake, and will adapt our policy according to the calcium intake of our patients, because the best way patients can take the calcium is through the diet, not through the binders, but best use the diet in a way. So, but first then you have to monitor, and this kind of service took only 2 minutes. We just exploded. So we have in-house service taking only 2 minutes to estimate the calcium intake of your patients, and then you can act upon. So all within the frame of personalized medicine, precision medicine. I think we need to go away from the one fits all and need to look at the patient sitting in front of you. A 95-year-old frail patient, you won't give 8 grams of calcium carbonate, you won't give even 8 pills of lanthanum, you just keep off. But a patient scheduled for transplantation will do all the best to keep his phosphate within the normal range. At least I would try to do so.
So my last question before giving the mic back to Austria, then, so your recommendations of a maximum of 1.5 grams of calcium would also include calcium acetate or carbonate from calcium binder. So
yeah,
if you give,
it's
say,
the total
2
calcium
grams,
intake.
Yeah, so if you give 2 grams of calcium acetate, which contains, I guess, 0.5 or so grams of calcium, then you would have to reduce your dietary intake to
yeah, but never
1.
reduce it. Yeah, never reduce it. Okay, the calcium intake, dietary intake is difficult to modify. I mean, then you would of course limit the protein intake, and then you know, patients are sometimes protein malnutrition is an issue, so we won't do. But so yes, we know calcium carbonate is 40% elemental calcium, and calcium acetate is 25%. Calcium acetate has a high phosphate binding. So we mostly use, if we aim to lower the phosphate, we mostly use the calcium acetate as the first choice of a calcium-containing phosphate binder. It's only when we want to supplement calcium that we use calcium carbonate, which has the additional disadvantage that you have to give it with the meals in order to get calcium absorbed. But that's all in the that's all in. So a lot of information, but it's all in this manuscript. So please, I would say, go to it and have a look at it and try to implement in your local center.
Yeah, it's a good advertisement, and I think it's a very nice paper. That's why we picked it as our NDD pick of the month. I think coming back to trial design, you have been completely right. I think we need to move away at some stage from these hard endpoints we are investigating. There are so many good examples also outside of course, CKD, MBD, where these focusing on end-stage kidney disease, for instance, or mortality has killed an intervention, and that's really the bad thing, I think, in nephrology. And so I certainly agree with that. I mean, also all the potassium binders we are seeing now, you know, they also have been approved based on potassium lowering capacity and nothing else.
Well,
So
not completely nothing else, because they also allow to continue calcium increasing interventions that are associated with improved mortality, right?
Yeah, sure. But I mean, but one thing I was really interested in when the VITAL study came out, and there was a sub-study looking at autoimmunity, and at least the short-term autoimmunity outcome, or at least the short-term, showed that autoimmune diseases were reduced by, I think, 20% or so. So do you have any explanation for that? Why supplementation would reduce autoimmunity in our patients?
Well, vitamin D receptor is present at many immune cells. So there is a biological plausibility to that. And that's all I can say. But it is well established that vitamin D plays a role in immunity. One of the earliest observations of that was the effect of UV light on tuberculosis. As you know, that's why people go to the Alps 100 years ago. So it makes sense to me, but I'm reluctant to look at results of sub-analysis of these studies, but there is plausibility that it might imply indeed a true mechanism.
Yeah, but I think the major concern on the VITAL and all these studies is indeed on the fact that they recruited patients with almost normal 25D levels. And Marc, you really nicely illustrated the potential, let's say, limitation of this recruitment of patients with normal 25D levels at baseline. A second limitation could be the short follow-up in a way. I don't know what the follow-up time was, but it was a couple of years, and you cannot expect that you will be able to decrease the number of cancers. At least in my opinion, that would be like almost impossible. So there's a lot of limitations, but at the end, it's of course it's a huge trial, and it's a randomized controlled trial. So what we should be very humble when we criticize this study. Because it's the best evidence we have, but not all. I mean, negative trials should always be very. I mean, we should be very critical about potential limitations. So that's our duty.
But one of the initial research questions of the VITAL was if the people in the US should all start using vitamin D supplements, and the answer to that is clearly no.
No, and that's also, I think, that was really very nicely being concluded in the editorial.
Yeah.
And the autoimmune outcome was just one out of many outcomes, and there might also be some, positive testing if you test too many hypotheses post hoc. So I believe this also needs some further confirmation, if any. But anybody ever does a study of that size again?
At least the bone outcomes were also completely negative.
Yep.
Yeah, talking of bone, I would have a practice question. Pieter, mainly to you. You mentioned denosumab and the risk of hypocalcemia in CKD. This is rather well known, I would say, and it's again confirmed by a very large observational study, very nicely done, right now published in JAMA not too long ago. Now, as you know, as we all know, DMAP has a very broad label, not excluding patients on dialysis, and we keep seeing that again and again and again, that people show up with hypocalcemia of unknown cause, and it turns out that they received some way or the other denosumab. Okay, so the practice question is, what do you think? What is and we all think and know that PTH drives bone turnover, and high bone turnover predisposes to hypocalcemia. If you cut off the PTH signal, so to say, then you have less efflux of calcium from the bone, and this triggers the hypocalcemia. So the question is, practice question, how low should PTH or any other marker, alphos, so bone-specific alphos, be in dialysis patients to say it's rather safe to start those patients on DMAP?
Daniel, this is a perfect research question. You asked me something which still needs to be researched in a way, but I do believe indeed that all the patients that develop severe hypocalcemia, it's post hoc a bad indication. So these patients should have been treated with a PTH suppressing agent or with parathyroidectomy first before starting this denosumab. But I mean, this is the case. People use the drug, and so we'll see this kind of hypercalcemia in the future. Coming back to your question, so what's the biomarker? As Marc told, we moving away from PTH because of this PTH resistance, which is very difficult to quantify. So we moving to really the bone biomarkers being the one that should guide us in making treatment decisions. And I would say that these bone turnover markers should be preferentially within the normal range, or let's say not above, and if in the higher range, I mean, not too high, because the higher, the more the risk of hypocalcemia. So that again would be a practical use of these bone biomarkers. So it goes beyond PTH control, so it also should be very interesting in I mean, guiding your osteoporosis therapy. So I would measure the bone biomarker. Is the alkaline phosphatase, it's too high, above the upper limit of normal, or the same for TRAP5B, or the same for bone-specific alkaline phosphatase. Think twice, and potentially you first need to control PTH better. And if you believe it's not possible, then go ahead, but then be prepared and eventually already increase your calcium dialysis, for example, or use calcium-containing phosphate binders, or add some kind of active or nutritional vitamin D before you start it, and monitor the calcium level up to 4 weeks following denosumab. The problem with the JAMA paper was that most of this denosumab was given by GPs. I mean, they're not aware of all these issues, and just give it because it's a patient with a fracture and they start just denosumab. And so I do believe that this kind of therapy should be best being centered in the dialysis centers, because we know the patients, we know there is high bone turnover, for example, and we should be very careful about giving this drug. And if we give it, we monitor the calcemia, because you know that the mortality was not, it was substantial. I mean, so it's not something which is completely innocent. So it goes with a price, and this is a price we can avoid.
Yep.
So thank you so much. Thanks for this academic hour, but surely much more. Thank you for drafting this great recommendations and for doing all the research in the last years and decades. We plan to have one more discussion on CKD MBD later this year during our Paris special, during the Olympic Games with Tilman Rüke and Markus Ketteler. But until then, have a nice spring weekend, hopefully with much of sun and much of vitamin D production. Thank you.
Thank you.
Thank you. Bye.
Enjoy the sun.